Hello, and welcome to the CAP Today webinar for Wednesday, May 16th. Today's webinar is entitled Herpes Simplex Virus Infections, From Cradle to Grave. I'm Bob McGonnagle. I'm the publisher of CAP Today, and as usual, I'll be your moderator and also lead a question and answer session after our speaker's formal presentation today. Our speaker is Dr. Jay Lieberman, who's with PRA Health Sciences, and I'll say more about him shortly when I introduce him to begin his presentation. I also wish to thank and acknowledge DiaSorin Molecular. Today's webinar is made possible by a special educational grant from DiaSorin Molecular. We want to thank them for their support. We couldn't do this without them. Now, before we begin our formal presentation today, I'd like to go over a few housekeeping items that I hope can make your experience more enjoyable and useful. First, I often suggest, and I suggest to most people, it would be a good idea to refresh your browser. That optimizes the syncing of slides on your screen as you look at the slides as they pass through. You'll be listening primarily through your computer speakers, but we do have a live attendance who will be with us the entire webcast. If you have any technical problem, you can call our helpline at 888-364-8804. You see that in the lower right-hand corner of your screen. At any time during today's webinar, you can ask questions or type comments in the Q&A box that you see right below the slides. And those we'll populate those and we'll triage those throughout today's webinar. And as I said before, at the end of the presentation, I'll allow our speaker to catch his breath, and then I'll launch into a question and answer session in the available time that we have. I want you to know that all slides and the audio of today's webinar will be posted at captodayonline.com in about 5 to 7 days. It will stay up there for approximately 1 year, and we encourage you to review and enjoy that, also with colleagues who couldn't participate today. Finally, let me say that CAP Today does not endorse any products or services that may be named within today's broadcast, and that my own comments were purely personal and, of course, should not be construed to be policy of the CAP Today or the College of American Pathologists. Once again, I want to thank DiaSorin Molecular. The webinar is made possible by a special educational grant from them. And now, let me turn and introduce today's featured speaker. Dr. Jay Lieberman went to medical school at NYU, studied at Children's Hospital in Los Angeles, and had a fellowship at Harbor UCLA. For many years, he was the chief of pediatric infectious diseases at the Miller Children's Hospital in Long Beach. He also had a tenure at Quest and Focus Diagnostics, and currently is at PRA Health Sciences. He is a specialist in pediatric infectious disease, and at PRA Health Sciences, he's the medical director of Pediatrics. It's a great pleasure for me to introduce to you Dr. Jay Lieberman, and I'll ask him to go ahead and begin his presentation now.
Bob, thank you very much. Greetings, everyone. It's a great pleasure to be speaking with you today about some fascinating viruses, Herpes simplex virus 1 and Herpes simplex virus 2, which cause diseases throughout the age spectrum. As Bob just said, I'm a pediatrician specialist in infectious diseases. If you're wondering what PRA Health Sciences is, we're a contract research organization, and so we help companies do clinical trials. And my job is to make sure that the participants in the trial remain safe, and that we do whatever we can to make sure that the clinical trial results are valid and important. So before I start talking about herpes simplex viruses, some of you have undoubtedly heard me speak in the past, either live or via the web, and you know that I am very proud and like to share pictures of my family. So this is my family, much larger than probably the last time you heard me, but I am blessed with four great children. So this is my family. Today we're talking about a different family, the human herpes virus family, and specifically two members of that family, HSV-1 and HSV-2. So a fascinating group of viruses, many of which are easily recognizable, and you understand the syndromes and the diseases that they cause. One of the things that all these viruses have in common, the herpes virus family, is that after the initial infection, they establish latency. And so they remain latent, quiescent in the human host, but can reactivate and cause disease. So we're going to talk about HSV-1 and 2, which are distinct viruses. VZV, you know, is the cause of chickenpox in children, and shingles or zoster, primarily in the elderly, but also in immunocompromised hosts. There's a new vaccine against shingles recommended for all individuals 50 years of age and older. EBV and CMV, often asymptomatic, but cause, again, disease, mono-like illnesses, but particularly in immunocompromised hosts, can cause severe disease as well. The other interesting thing to point out about this family of viruses is that there are two viruses here that can cause cancer. EBV can cause nasopharyngeal carcinoma, and the human herpes virus 8 or Kaposi sarcoma-associated herpesviruses obviously is a cause of Kaposi's in HIV-infected individuals and other immunocompromised hosts. But today we're focusing on HSV-1 and HSV-2. I'm going to today focus on these four diseases, the first two of which are very common, the last two of which are much more rare, but potentially much more serious. So let's start by talking about genital herpes. This is the cover of a Time magazine back from 1982. And the cover story is today's scarlet letter, the big H of herpes. And 1982 harkens back to a much more innocent time when herpes was thought to be the most serious virus you could get that was sexually transmitted. 1982, we already knew, and I would argue that HSV is probably the third most serious virus you can get from sexual contact that begins with the letter H. So 1982, we had the first cases that reported what we later understood was caused by HIV. Think about the impact that's had over the past 30 plus years. The other virus that you can get sexually transmitted, starting with H, is incredibly important, is human papillomavirus, HPV, which we now know causes cervical cancer and other anogenital cancers and head and neck cancers. And oh, by the way, there's a vaccine that can prevent HPV that you know about. My two eldest daughters, who are 9, have already gotten their first dose. If you have children between the ages of 9 and 26 who've not been vaccinated against HPV, please do that. But in 1982, this was the scarlet letter, herpes. So genital herpes, it's a chronic lifelong infection. The virus established latency. The incidence, about 500,000 new cases each year in the United States. The prevalence, approximately 50 million Americans have been infected. So over the course of our lifetimes, about 1 in 3 sexually active adults will be infected with genital herpes. In addition to the disease manifestations that are caused, we'll talk about those in a moment, genital HSV-2 is also a risk factor for HIV acquisition. Because of the lesions, the ulcers it can cause, it makes it more likely that if someone comes in contact with HIV, that they will be infected with that virus. And so that's an important role it plays as well. I'd also highlight the fact that currently about 20% of genital herpes in the United States is caused by HSV-1. And this percentage has grown over time. It reflects an increase in oral sex in the United States. Another manifestation of that increase in oral sexual activity is the increase in head and neck cancers caused by HPV. So both viruses can cause, HSV-1 and HSV-2 can cause genital herpes. This looks at the prevalence among U.S. women. In green, it is HSV-1. You can see that the virus is ubiquitous, and the majority of women and men in the United States get infected with HSV-1 over the course of their lifetime. In the purple color, that's HSV-2, the vast majority of which is a cause of genital herpes. And as we'll talk about in a second, many people who are infected with HSV-2 are not aware, do not recognize the fact that they've been infected. So with genital herpes, and with all the herpes viruses, there's the infection you get, the disease you get when you're infected for the first time, and there's the diseases you get when the virus reactivates. I'll say right up front, I'm going to talk about primary infections, and I'm not going to use the term exactly accurately. Strictly speaking, a primary infection with HSV-2, for example, means that it's the first time you're infected with HSV-2 and you do not have antibodies against HSV-1. HSV-1 and 2 are distinct viruses. There is some degree of cross-protection. What does that mean? If you're infected with HSV-1, you can still get infected with HSV-2. But if you do, your symptoms tend to be a little more mild. A primary infection, again, implies you've not had HSV-1 either. I'm going to use primary infection and first infection kind of interchangeably, but again, I want to acknowledge that strictly speaking, that's not correct. But when you get your first infection with HSV, generally HSV-2, it's typically associated with more severe signs and symptoms. You've got prolonged viral shedding. We'll look at this in a moment, and high rates of both cervical and urethral involvement. You also tend to have systemic symptoms that may include fever, headache, malaise, abdominal pain, among other findings. You've got systemic symptoms, you've got high quantities of the virus that you're shedding, and interestingly, up to 36% of women and 13% of men develop meningitis, an aseptic meningitis, which is self-limited. I saw a patient in my career, was a teenage girl who'd come in with headache and stiff neck. They did a spinal tap. They sent off PCR for enterovirus and HSV, and when it came back positive for HSV, they panicked, concerned that she might have, HSV encephalitis. By the time that she was referred to me, was 2 days later, she was completely well. She had aseptic meningitis due to HSV, which is different than having HSV encephalitis. Here's the manifestations of primary HSV-2 infection. And again, the constitutional symptoms, the systemic symptoms, the meningitis I spoke about. Look at the last two lines of this slide. The mean duration of viral shedding is about 11 or 12 days. The mean duration of lesions is more than 2, going on almost 3 weeks. And so during this primary infection, you're clinically ill and you're sick for a long time. This is the only picture I'll show of genital herpes. When you see these vesicles, the differential diagnosis is pretty small, and you can generally make a clinical diagnosis of genital herpes. However, the clinical presentation is not always classic, and not everybody has these painful, and they're usually painful, vesiculopustular lesions. Ulcers are also very common with these, and when there's only ulcers, you might not recognize it. And there are a number of atypical presentations that are often unrecognized by not only the patient, but by the physician as well. And these include fissures, irritation, cervicitis, proctitis, cystitis, and urethritis. And so women can present particularly with dysuria or vaginal discharge. And again, these presentations are often not recognized as being due to herpes. In addition, there are people who are infected who have such mild disease or asymptomatic that they don't understand that they're infected, as we'll talk more about in a little while, but they do shed the virus intermittently. And because they're shedding the virus, they're contagious. And so a lot of the transmission of genital herpes occurs from someone who has no idea they're infected to their unsuspecting partner. Laboratory diagnosis, as I'll say in a second, the gold standard for a long time was isolation of the virus and culture. We'll talk more about that. There is antigen detection. Everyone's familiar with the Zank prep. The Zank prep really should not be used anymore. It's both not sensitive enough, nor is it specific enough. Not specific enough means that if you do have a positive Zank, you don't know if it's HSV or VZV, and you don't know whether it's HSV-1 or HSV-2. And so, what's really taken the forefront now is, DNA amplification methods, usually PCR. And we'll talk more about that, and we'll talk more about serologies. So again, viral culture was the gold standard, I would say, until recently. The problems with viral culture, it requires live virus infected cells. You have to take special care of sampling and in transport. For active lesions, you want to collect the vesicular fluid or the exudate from small vesicles, meaning the newest, the freshest vesicles, was the method of choice. The major problem was the sensitivity is low, particularly for recurrent lesions, because when someone has recurrent genital herpes, there's a lot less virus in the lesions, and there's a lot less virus for a short period of time, and so the sensitivity declines rapidly as lesions begin to heal. So that a positive culture result obviously confirms the diagnosis. However, a negative could not rule it out. Molecular testing has really become the test of choice, not only for the disease we're going to talk about later, but both for cutaneous and mucocutaneous lesions that we're going to be talking about at the beginning of this talk. Obviously, increased sensitivity, so positive results longer into the duration of the illness, less dependent on the collection and the transport conditions, faster results than a viral culture if you have access to molecular testing, and increasingly available. Not only now in the reference laboratory, but there are systems that allow you to make a diagnosis in your laboratory. And so again, molecular testing has really become the test of choice for cutaneous and mucocutaneous lesions thought to possibly due to HSV. I do want to talk a little about serologies, because when I was laboratory director, remarkable how many calls I got about HSV antibody testing. So within the first several weeks after infection, people who are infected develop both type-specific and type-common antibodies to HSV, and these antibodies persist. But there is cross-reactivity, these type-common antibodies. And so if you are going to do serologic testing, you have to make sure that you do type-specific HSV serologic assays based on the specific glycoprotein G2 or glycoprotein G1. And providers should only request type-specific serologic assays when they're doing antibody testing on their patients. In the absence of that, if it's not a type-specific test, you will get a result that says HSV-2 antibodies, and you cannot be sure whether it's HSV-2 indeed or HSV-1. And obviously, a positive HSV-2 test, has implications for the patient who's been tested or has requested testing. The other thing I'll add here is, many labs will do IgM testing for HSV, and you don't want to order that either. And the reasons for that is it does not distinguish between HSV-1 and HSV-2, despite what the result may say. And in addition, we think of IgM antibodies in general as indicating acute or recent infection, but the reality is with reactivation disease, you can get a spike in IgM as well. And so I don't feel it provides any real value if you're trying to evaluate your patient. So when might you want to do antibody testing? Here are some clinical scenarios. You've got someone with recurrent genital symptoms or atypical symptoms, as we talked about, but your specific test, PCR culture, is negative. And that may just be a sampling problem or a timing problem. You want to clinically diagnose a recent episode as genital herpes, but you don't have laboratory confirmation. You have a patient whose partner has genital herpes, and you want to know if they've been infected. Because if you do have a partner who's infected and the other one who's not, you want to counsel them on how to avoid infection. And also consider HSV antibody testing for those who present for an evaluation for sexually transmitted infections, people who are infected with HIV, and men who have sex with men who are at increased risk for HIV. So there are clinical scenarios where having an antibody result, a type-specific antibody result, can be very beneficial in counseling the patient. This is a slide from a now very old study that looked at acyclovir for primary genital herpes, compared IV, oral, and topical therapies. There's no placebo here, but you can see that topical acyclovir is by far less effective than oral or intravenous therapy. And so do not recommend topical therapy if you're going to treat someone who has an HSV infection. IV is a little better than oral, but you're going to use oral therapy unless the patient is really systemically ill and requires hospitalization. The other thing to point out here is that even with oral therapy, you can see the duration, the percent of patients shedding HSV, continues out for days and days. And again, because primary genital herpes, they're shedding virus for such a long period of time, they're clinically ill for such a long period of time, giving them antiviral therapy really does hasten healing of the lesions. It reduces the duration of shedding and reduces their systemic symptoms as well. So the recommendation is to treat patients who have a first clinical episode of genital herpes. You can see the recommended regimens here. Valacyclovir, famciclovir, they're prodrugs of acyclovir. They're better absorbed orally, and so therefore require less frequent dosing. But again, the recommendation is to treat someone with a first clinical episode of genital herpes, although some of those patients you treat will actually be having a recurrent episode just because you don't know that they had and they don't know that they had a previous episode. When we look at recurrent infection, a very common problem, and some people have frequent recurrences, meaning 10 or more times a year. The thing that I would highlight here, the mean time to crusting, the mean time to healing, the mean duration of viral shedding, much, much less than with primary infection. And so there is not a recommendation to routinely treat people with recurrent infection. By the time you recognize what they have, they start the prescription, you're going to have minimal impact on their clinical course. On the other hand, suppressive therapy for those who have recurrent genital herpes can be highly beneficial. Suppressive therapy reduces the frequency of recurrences by 70 to 80% in patients who have frequent recurrences. Many people who get suppressive therapy experience no outbreaks. It is also effective in patients with less frequent recurrences. And so this is a decision that's made in conjunction with the patient's physician, but it can be highly effective. Here are the recommended therapies for people who have recurrent genital herpes. It's a daily therapy, and basically the dosing is just less frequent. It's the same dose of medication you give for therapy, you give it less frequently. And again, can be highly, highly effective. Let's move on from genital herpes to its analog, which is the other mucocutaneous lesions, which is orolabial herpes. Here are pictures of young children with primary herpes gingivostomatitis. And every year while I was in the hospital, we'd have several kids admitted with such severe primary oral disease that they couldn't drink, they couldn't eat, and they would get dehydrated. And we'd have to admit them to the hospital with primary HSV gingivostomatitis. Again, this infection typically occurs in young children. They develop vesicles, but the vesicles often rapidly rupture, and you wind up with these ulcers. And so the clinical diagnosis can be a little tricky if you don't recognize that by the location, depending how long the patient's has been sick, they may not have classic vesicles. These children may drool and therefore may develop lesions down to their chin and neck. And similarly, as you kind of saw in the picture above, the previous picture, it can also extend up as they touch their mouth and inoculate the virus in other parts of their face, including sometimes the eyes, where it can cause serious illness. Again, analogous to primary genital herpes, when it is the primary infection, they shed virus for a prolonged period of time in their oral secretions, and they're sick for a long time. This is a study done about 20 years ago now where they randomized kids with primary HSV gingivostomatitis to acyclovir, oral acyclovir, or placebo, where they can give oral. And as you can see here, in the blue acyclovir, the red placebo, giving therapy with acyclovir significantly reduced, clinically significantly reduced, the days of new lesions, the days of fever, the days they had problems drinking, and the days of viral shedding. And so the recommendation, again, analogous to primary genital herpes, if you have a child with primary herpes stomatitis, you want to treat with acyclovir. The diagnosis often clinically is sufficient. It's just absolutely classic. If there's any doubt, or sometimes to confirm, again, culture or increasingly PCR is the way to make the diagnosis. If they're shedding high quantities of the virus, you catch them early, the culture is going to be positive. But again, in many areas, PCR has become the diagnostic test of choice. You know, more commonly, and very commonly, you see recurrent disease, cold sores. And you know, patients who are infected with HSV-1 are infected forever. They'll shed virus in their mouths and get what we classically call cold sores. A very large reservoir of the virus. We saw the incidence, you know, the virus is ubiquitous as you age. 60–70% of people will be infected at some point in their lives. And 1 to 5% of people are shedding HSV at any given time. As far as treatment is concerned for cold sores, generally you don't treat. Reason, again, analogous to recurrent genital herpes, short duration of illness, low quantities of virus. By the time you start, you're not going to have a significant clinical impact. So you don't treat unless you can begin therapy during a prodrome. So some people know when they're going to have an outbreak. They start getting a tingling sensation. They've had it before. They know they're going to develop, you know, cold sore or fever blisters. And if you can begin therapy during the prodrome, you can reduce the duration of illness. Or you can treat, if you can begin the therapy prophylactically for predictable reoccurrences. And so again, some people know that they're going to have an outbreak. For example, every time they go skiing, the combination of the sun, the cold, they get cold sores, in which case giving them, you know, a prescription to prevent a reoccurrence can be beneficial. I just want to show you some pictures of 2 different illnesses that I saw not infrequently during my career as a PEDS ID doc. You see these lesions on a hand. Is this hand-foot-mouth disease? Here's some more pictures. These are pictures of herpetic whitlow. And this occurs when someone has, you know, is shedding HSV orally, and they inoculate their fingers or their hand. This picture on the left looks exactly like the picture I saw once of a child who got admitted. The finger looked just like this. The treating clinician thought that they had a cellulitis of the fingertip. They started antibiotics for Staph aureus, including possible MRSA. They had debrided the finger twice, and it just wasn't getting better. And so they called me, and I said, oh, this could be herpes. And the child did not have a lesion in the mouth, but I sent a swab, and indeed it was herpes. The child did not need debridement, did not need antibiotics. The child needed acyclovir and got better quickly. Here's another disease that I saw increasingly for some reason during my career, children presenting with a rash, like this picture shown on the left. And the lesions may not look vesicular, but the key thing is to think with these discrete lesions, could this be herpes? And the question you want to ask clinically is, does the patient have eczema? Because this is a picture of eczema herpeticum. And again, I've seen kids not diagnosed, misdiagnosed, being treated with antibiotics for even like in one kid looked like almost a staph scalded skin syndrome. But the history of eczema was key. And as time went on and cell phones became more popular, I'd get calls from pediatricians. I'd say, hey, send me a picture of the rash. And when I saw this, I'd ask the doctor, the referring physician, hey, do they have eczema? Yes. Oh, that's eczema herpeticum. And so that recognition of the link between disseminated HSV that may not look typical and people with underlying skin diseases is critical to making the diagnosis. So let's move on now from two very common cutaneous and mucocutaneous manifestations of HSV viruses. Ooh, I just said HSV viruses, that's awful. Of HSV-1 and HSV-2 to much less common but potentially much more serious conditions. So let me start with neonatal herpes. How does a newborn get infected with HSV? The majority of cases are occurring peripartum, meaning, during delivery, in a woman who has active lesions or is shedding virus at the time of delivery. Much less commonly acquired before delivery in utero, and less commonly after the patient's already been delivered. How do you get it postpartum? You could get it, for example, someone with oral herpes, kissing the baby on the mouth, for example, inoculating the baby, and then you can get systemically ill from that. The epidemiology, the risk to a newborn is primarily, most importantly, related to the type of maternal infection. If mom has a primary infection at delivery and has active lesions or is actively shedding virus, the risk of that newborn becoming infected is between 30 and 50%. So very high risk. Whereas if the mom has an active lesion due to recurrent genital herpes, the risk, even to the infant born vaginally to a mom who has a recurrent lesion, is less than 3%, probably in the neighborhood of 1 to 2%. Why is the risk much lower? Two reasons. First of all, lower quantity of virus, less virus shedding. The second reason, mom already has maternal antibodies that she's probably passed on to her full-term or near full-term infant. And those antibodies will often protect the child from becoming at least systemically ill due to herpes. So we know who's at highest risk. The problem is that, as it says here, 60 to 80% of infants with neonatal herpes in the U.S. are born to asymptomatic moms with no history of genital HSV. And we'll talk more about that in a second. Why might someone not know that they've been infected or have genital herpes? I think this study illustrates it very nicely. What they looked at was 53 people who were HSV-2 positive using type-specific antibody testing who had no history of genital herpes. They cultured these people and they found that the daily cultures reveal viral shedding about 3% of days. So again, these people who have been infected with HSV and don't know it, they're still shedding virus. And that puts their partners at risk, and if they're moms, potentially puts their newborns at risk. Most interesting to me is that after they educated these seropositive people about signs and symptoms about genital herpes, 62% reported having typical ulcers, crusts, or blisters. So they just hadn't recognized that these non-specific symptoms that they had were due to genital herpes. So here are the challenges of trying to prevent neonatal herpes. The history is not generally available, meaning, again, as I just said, most infected infants are born to moms who have no maternal history. They don't know they've had genital herpes. In addition, the history is not particularly helpful because women with a known history of genital herpes are at lower risk of infecting their infant compared with women who acquire HSV during pregnancy. And so, again, unlike many diseases, the history doesn't really help us. Neonatal herpes disease can be classified into three distinct syndromes. First is disease limited to the skin, eyes, and her mouth, so-called SEM disease. So these are people who have lesions of the skin, eyes, or mucous membranes. That's the most common presentation. Central nervous system disease, meningeal encephalitis, is about 30% of cases. Disseminated disease, which involves multiple organs, including not only the central nervous system, but potentially the lung, HSV pneumonia, HSV hepatitis, plus minus SEM disease, is about a quarter of cases. This classification is important because it tells you to a large degree how the neonate's going to do. From an old study that compared acyclovir and an old antiviral vidarabine, the results are not really important. However, what I want to focus on here is if you had infants with SEM disease and you treated them, 100% survived. Whereas if you had central nervous system disease, neonatal herpes meningitis, you had mortality and morbidity we'll talk about in a moment, even with treatment. Patients with disseminated disease did the worst. Even with therapy, if they presented with disseminated infection, about half died. This is from another study that looked at high-dose acyclovir and also looked at the difference by HSV types. A patient who presented with SCM disease and was treated, they never died and almost always was completely normal. Why do these patients do so well? In part because oftentimes they're infected passing through the birth canal. They might have an abrasion from delivery or a scalp monitor, and they get a local infection from someone with recurrent disease. So they have antibodies, low virus titer, and they have disease that's limited. Let me emphasize, though, because they do well doesn't mean they don't need treatment. Some of these kids, if they are not treated, will progress, develop CNS disease or disseminated disease. If they present with meningitis, you can see HSV-2 is worse than HSV-1, more likely to die, more likely to wind up with sequelae. And as you can see here, only about 20% from this study wound up unscathed from the infection. Again, if it was disseminated disease, it didn't matter whether you had HSV-1 or HSV-2, your prognosis was bad, and about half of patients died. How do these patients present? If they present with SCM disease or disseminated disease, they usually present in the first week of life. Whereas patients with central nervous system disease usually present during the third week. The median age at onset, about 16, 17 days. And just something you want to remember when you're evaluating a child to think about it. So, for example, a 16-day-old who presents with an aseptic meningitis. From the study where they were looking for neonatal herpes and using high-dose acyclovir, the mean time between the earliest symptom and diagnosis, 5 to 7 days. And one of the things I want to emphasize both with neonatal herpes and herpes encephalitis, there's time pressure. And the earlier you diagnose, the better the patient's going to do, generally speaking. And yet oftentimes there are delays. So here's pictures of two different infants with neonatal herpes disease. They've got skin lesions. The one on the left, fairly obvious, they've got vesicles. You'd better think about herpes if you see this. The one on the right can be a little more challenging. And having lesions on the scalp, you may not be able to see if the child has a lot of hair. They may not be classic vesicular lesions. But if the thought even crosses your mind about herpes, you've got to do a head-to-toe exam, and you've got to look at the scalp. And oftentimes these kids will present, they've had a scalp monitor in place, and so it was that disruption of the skin barrier that predisposed them to get infected while they were passing through the birth canal. Easy if they present with skin lesions, but 17 to 39% never have skin lesions throughout their course. They don't necessarily have fever, particularly if they have SCM disease, and half the infants have seizures before they're diagnosed. And so the challenge is thinking about it and doing your evaluation. What's your diagnostic evaluation? CBC, liver function tests. If you've got elevated liver enzymes, you've got disseminated disease. And doing the spinal fluid. You want to look for virus from multiple sites and PCR. From the CSF, certainly, and many people now do blood. You don't do antibody testing. Any antibodies you detect reflect maternal antibodies, not antibodies from the infant. PCR from the CSF revolutionized the diagnosis of central nervous system, neonatal herpes and herpes encephalitis. The literature says the sensitivity ranges from 75 to 100%. It's much higher than that. Using better tests, you get well above 90%. The point, though, is a negative test does not completely exclude the diagnosis, depending on where they are in the clinical course. And the recommendation now is to repeat the PCR at or near the end of therapy, and if it's positive, that correlates with poor prognosis. And if it's positive, you continue therapy. Very old study, retrospective, lower doses of acyclovir, shorter durations. Bottom line, though, if you were PCR positive at the end of therapy, that's not a good sign. and you want to have a negative PCR before you conclude therapy. A positive blood PCR means that they're infected. And again, it's increasingly being used. It does not tell you the extent of disease because you can have viremia with any of the different classifications. Interestingly, the PCR can be positive for weeks, and we don't know what that means, and there's no data to support the use of serial blood PCRs to monitor response to therapy. So if you have a positive, the kid's infected, treat. You want to do the CSF, the full workup. You do the CSF at the end, but you don't do further blood PCRs. So who do you treat? Anybody who's culture or PCR positive, regardless of whether or not they have systemic symptoms. You completely evaluate them with CSF, and you also do an MRI looking for evidence of CNS disease. Kids who have typical presentation, and you strongly consider for any infant less than a month while you're evaluating them who has this aseptic meningitis. Therapy is now 60 milligrams per kilogram per day. 15, 20 years ago, we were using 30 milligrams per kilogram, 10 per kilo per dose. 2 weeks for SEM disease, at least 3 weeks if they have meningoencephalitis or disseminated disease. And as I've already said, if the CSF PCR is positive, you continue for an additional week. And then you give 6 months of suppressive oral acyclovir therapy following their treatment for neonatal disease. Very quickly, studies showed 60 milligrams in blue, 60 milligrams per kilogram per day, fewer deaths in patients with CNS disease, fewer deaths in those with disseminated disease. So that is now the standard of care. As far as oral acyclovir suppression, one of the things we recognize with these kids who we treated, not infrequently would have recurrences of their skin lesions. And we would reevaluate them, and some of them we would see had a recurrence of disease, and they might even have a recurrence of their CNS disease. And even in those kids who we never identified as having recurrence of CNS disease, if they had frequent recurrences, there was a tendency to see poorer developmental outcomes. And so this study looked at giving them 6 months of suppressive therapy, it reduced skin recurrences, and there was a hint at better neurologic outcomes. And so again, the recommendation is 6 months of oral therapy after they complete their primary course of therapy. In the interest of time, I'm going to skip over how to manage newborns. But again, the highest risk is maternal primary infection. If that is the case, you know the mom has primary infection. You want to get cultures from the infants at 12 to 24 hours. You wait to get the cultures. A positive culture from shortly after delivery could reflect maternal culture, a maternal virus rather than infant's virus. Many people would treat them empirically with acyclovir. If moms are having a recurrent infection, you obtain cultures and then you monitor closely. So let me finish up by talking about herpes simplex encephalitis. The left is an MRI. The right, the first time I showed this picture at talk, I said it was an autopsy. It's obvious. I said it was a biopsy. It's actually an autopsy. And what this highlights is that HSV has a predilection to affect the temporal lobe of people who are infected. HSV encephalitis is the most common cause of sporadic encephalitis. It's usually caused by HSV-1 that's reactivated, and we don't understand why that occurs. There's no real seasonality. Overall, it accounts for about 10% of all encephalitides. It's challenging, and many patients with encephalitis do not get a specific diagnosis. But HSV encephalitis, you should be able to specifically diagnose, and is treatable. And so it's critical that they be evaluated for HSV. About a third of cases in people under 20 years of age, so we did see it in children, more than half of cases in people over 50. It's a significant cause of morbidity and mortality. Untreated, about 70% die, and of those who live, 97% don't return to their previous level of function. With treatment, mortality is significantly reduced by 3 months, about 15%, but if you follow them out to 18 months, about 25% of patients will die, even with therapy, due to the neurologic complications. So a rare disease, but an awful disease. The earlier you treat, the more likely you are to have a good outcome. How does it present? Altered level of consciousness, hallucinations, strange behaviors, fever, abnormal spinal fluid. Occasionally you'll have a normal CSF. usually see elevated CSF protein. That protein will increase over time if you do serial LPs. Aseptic picture with a lymphocytic pleocytosis. Seizures are very common. 60% of people have seizures, most of which are focal, but occasionally they are generalized seizures as well. Diagnosis, EEG, neuroimaging studies, MRI can show the focality, and if you see temporal lobe, that should certainly heighten your suspicion of it being HSV. Before we had PCR, you had to do brain biopsies, just awful. But a CSF HSV PCR is the gold standard. About 98% sensitivity, rarely can be negative early in the disease course. So a negative doesn't completely rule out. If you had a patient who still had a strong clinical suspicion based on the clinical presentation, perhaps the imaging or EEG studies, you'd want to repeat the CSF to look for HSV by PCR. Treatment in adults, 30 milligrams per kilogram per day. Some experts recommend a higher dose, but in adults, that often leads to nephrotoxicity. In children, you would use a higher dose of acyclovir. You treat at least 2 to 3 weeks and repeat the LP near the end of therapy to document the PCR is negative, as we talked about with neonates. And again, just an old study, which again highlights acyclovir is actually better than vidarabine in adults with HSV encephalitis, still a bad disease. So the summary, HSV-1, HSV-2, they're common viruses, and they cause a broad range of disease manifestations across the age spectrum. Infections range from asymptomatic to mild symptoms, or can be deadly. You have symptoms and disease both potentially from the primary infection or from reactivation of the latent virus. And the diagnosis of CNS infections, cutaneous, mucocutaneous infections, increasingly is molecular diagnostics, and it's really changed the way that we approach and diagnose these infections. So that concludes my presentation. At this time, Bob, I'll hand it back to you.
Dr. Lieberman, thank you very, very much. We get many wonderful presentations, but only rarely can I say we've got a truly encyclopedic presentation today on the herpes simplex virus infections, indeed from cradle to grave. It was a magnificent talk. Obviously, I'm particularly delighted we'll be archiving it because I have a feeling many laboratory folks will like to review it, and it could serve as the basis of a very useful in-service for attending clinicians and others. As I let you catch your breath, we won't start with a question, but you have a colleague, Ken Van Horn, who was on today, and he would like me to say hello to you. So I will say hello on Ken Van Horn's behalf.
And so now hello to all our former Focus Diagnostic colleagues. It's a wonderful place to work. I also see Barbara McKee is on there, and Barb is a former colleague at Long Beach Memorial Miller Children's. And so greetings to anybody from those days as well.
Yes, absolutely. And Barbara is a very regular participant in our webinar, so we always welcome her. And in fact, we're going to take our first question from Barbara McKee. In our lab, we've been doing molecular testing for HSV-1, HSV-2, and VZV for about 1 year. Interestingly, and not uncommonly, we detect VZV from genital lesion specimens. Could you comment on that? You alluded to it in your talk, but give us another comment.
Yeah, that's fascinating. I'm not aware of a lot of literature about that. Obviously, so there's two scenarios. One, it could represent a primary VZV infection. Why might you see it in a limited geographic area? Most commonly, you might see that in someone who's been vaccinated against chickenpox, never had an infection. If they do get an infection, you develop a breakthrough disease that's characterized by relatively few skin lesions. Sometimes it can localize there, so that would be their chickenpox. The other scenario would be shingles. Not a common place for shingles to manifest, but it's certainly possible. You'd expect it to be unilateral. You'd expect it to be dermatomal. You'd expect it to be characterized by a lot of pain. So those are the two scenarios where you might find DZV instead of HSV, as far as I can think. Clinically, the lesions would look the same, and again, an area where molecular diagnostics would help. I'll add there, along those lines, another scenario I saw several times was a patient who would have recurrent vesicles, for example, around the eye. And the idea was that the diagnosis, well, they're having shingles. But recurrent shingles is possible, but not common. And usually when someone has recurrent episodes of shingles, they're not in the same location. And what you want to do is think, well, maybe this is not VZV, but it's HSV. And that's, again, where molecular testing can help you identify what it is and help you decide how to treat.
Thank you very much. Wonderful question and a great answer. Let me ask you another question now, Doctor. How often do patients with documented recurrent HSV infections have a negative type-specific antibody test? That is to say, the patient had a positive PCR for HSV-2 on lesion in January and a negative glycoprotein G2 antibody. Was the antibody still negative for HSV-2 in July?
Yeah, so by July, five months later, you would have expected the antibody test to be positive. It can take time for the antibodies to develop. And so a negative test, at 2 weeks or even 4 weeks after the lesion, that's not that surprising. By 5 weeks, that does surprise me. Obviously, I trust the PCR result. For academic sake, I'd probably want to repeat it again, potentially at a different lab. Make sure it's HSV, it's type specific. That is not very common.
Very good, thank you. And of course, we have, as usual, and as very welcome questions around specimen types. What's ideal? What is the preferred specimen type in your experience and in your opinion for a PCR for HSV in blood? Plasma or whole blood?
I don't know that answer, quite frankly.
Okay.
I just don't know. I'm not aware of the studies that have compared. Most people do whole blood, but I'm not aware of studies that directly compare it, and I'm sure they exist. I apologize.
Okay. That's quite all right. We'll be able to follow up here, and as usual, I'll direct questioners also to the excellent technical staff at DiaSorin Molecular, who may be able to help elucidate further any questions that you may have, including some we may not be able to get to today. Here's an interesting question. It reads as follows. We currently offer a comprehensive women's health molecular panel for BV, yeast, and STIs using a vaginal wall swab. We also have a molecular genital ulcer panel, including HSV-1 and 2, which we require on an unroofed ulcer sample. All assays are run together on an open array. We have found the vaginal swabs can come up positive for HSV-1 or 2 without the provider ordering the genital ulcer panel. What do you suggest about reporting out on these positive vaginal wall swabs when there's no apparent active infection?
So as I said, people who have been infected will shed virus intermittently in the absence of lesions. And they may do that 3% or more of days. So I would presume that a vaginal PCR positive for HSV-2 reflected they've been infected in the past. I'd probably follow that up with a type-specific antibody test. And if that came back positive, that would absolutely confirm it. Again, not doubting the diagnosis, but when you're telling someone that they have genital herpes and they're completely unaware and don't have lesions, I'd like to have as much evidence as possible because, again, it has implications both emotionally as well as, risk to their partners, risk to potentially to children they've not yet born, et cetera. But I would tend to believe the results.
Thank you very much. We have a question here. Actually, several have been around the same general question. I'll ask it as an individual here. Is there any need ever to perform an antiviral resistance assay for isolated HSV in recurrent disease?
So you can get resistance. The classic presentation of that, oftentimes immunocompromised patients, but not always, who've been on prolonged acyclovir therapy. So the time I would consider it perhaps would be someone who's put on, for example, suppressive therapy for recurrent disease. They seem to do well for a while. It's working, and then perhaps they start having frequent recurrences again. And that would be a time to ask the question, did the long-term therapy induce resistance? And it can occur. But I would certainly not do it routinely.
Very good. Thank you. We have a question here, which I'm sure is on the minds of many, regarding positive tests that are slightly over a reference range. Could those ever be considered an example of the cross-reactivity between the two viruses within the test, or would they both be considered positive then? I hope that's clear. I know you can read it also for yourself.
So I presume they're asking about type-specific, HSV-2 results, and so low positive results can represent false positives. The reason for that was cross-reactivity. We don't think so. But if you have a low positive near the cutoff value, again, that'd be worth following up, whether it's by supplementary testing, for example, Western blot testing, or potentially even repeating the result to see if you get a higher value, perhaps they're further out from their disease. But there are false positives, and again, that can have real implications. So, as always, when the test result may not be concordant with your clinical impression, or the result is, only mildly positive, follow-up testing certainly could be indicated.
Very good. Thank you very much. We have another question from Barbara McKee. When the neonatologists order both HSV culture and PCR, do you really need to fulfill this culture request in addition to the PCR? So
I presume you're saying from the CSF, in which case I would argue that there's no added value to the culture result. You're not going to grow the virus if the PCR is negative. Sending culture results from different body sites would certainly be indicated, because you could have a negative CSF PCR, but a positive culture from the oropharynx, the rectum, etc., depending on the stage and the timing of the disease, will be positive. So, sending both on the CSF doesn't make any sense to me. Sending both cultures and PCR from different sites can be valuable.
Very good. And you alluded in your introduction to some very important vaccines, including for HPV, which has now a second generation. Do you see any vaccines for HSV in the near future? Near future would be wishful thinking. There have been a lot of efforts over the years to develop vaccines to prevent HSV infection. To date, none has been as successful as we'd like. There have been hints at success, but the drive to develop an effective vaccine is not over. People are looking at companies looking at different strategies, but it's not here now, and it's not in the very near future. Right. Could you comment on something that's specific about this family of herpes simplex that makes that particularly difficult to achieve, i.e. an effective vaccine? Well, it's really defining what is a protective immune response. So after you've been infected with HSV-2, for example, and you have,
genital lesions, you've had oral lesions, you develop antibodies, and yet those antibodies do not protect you against reactivation or recurrences of disease. And so the antibodies you generate are not protective, again, analogous to HIV or hepatitis C, that the presence of antibodies don't mean you're protected. The presence of antibodies mean you're still infected. And so you've got to develop a host immune response to the vaccine that's better than the response to the virus itself. And that's the challenge.
Thank you very much. We have a question I know is on the minds of many, and I'll phrase it as follows. Do the serologic HSV antibody glycoprotein G1 and 2 results produce too many false positives based on the manufacturer's interpretation criteria? And is that in part what is fueling this move to molecular methods?
Well, so the second half of the question, you're asking two different questions with this, the molecular diagnostics and the serologies. So for acute illness, you want to do molecular. If, there's a role for serologic testing, and I spoke about the specific circumstances, so that where they can be helpful. Are there too many false positives? One, that's a subjective question. But what I'd add is, with any test, the positive predictive value is dependent not only on the likelihood of infection, but the incidence or prevalence of infection. So if you're doing, for example, to be silly, if you're doing HSV-2 serologic testing on 10-year-olds, almost every positive is going to be a false positive. You shouldn't be doing that population. If you're doing it in a population of people who are at a sexually transmitted infection clinic, most of the positives are going to be true positives. So I would suggest, and we looked at these tests a lot, they're really good tests. There are false positives. The value of the test is related to what's the population you're testing it in. The lower risk the population, the more false positives you're going to have. And again, most of them will have low cutoff values. They'll be near the cutoff value, rather, low positives, and that'll give you a clue in a low-risk population that it may not be a true positive.
Thank you. Thank you very much. I hope that answers the questioner's question. Along with me, there were other people who were impressed with your presentation on encephalitis, and we have a question about the frequency for those who are HSV-1 or 2 positive developing encephalitis in their lifetime. Is there any data on that?
Yeah, it's an extraordinarily low risk, and all of us who've had cold sores, I've not, by the way. Everybody's had cold sore, they see that and they say, oh my gosh, I'm at risk. This is a rare disease. There are a couple thousand cases in the United States each year, despite the fact that 60 to 70% of us are infected. So you're talking, hundreds of million people infected and, a couple thousand cases. So, this is not something to lose sleep over.
Very good. Thank you. And finally, could you estimate for us the rates of transmission under various scenarios, that is to speak to an uninfected sex partner at times when there is no apparent outbreak of genital herpes?
And I'm not going to give you numbers. I don't remember the numbers, but a number of factors obviously go into whether or not someone gets infected from a partner. Transmission is higher male to female than the reverse. Transmission is obviously higher in someone who's having a primary infection than in someone who has recurrent disease, a lot more virus. And transmission is higher when there are abrasions of the skin or the mucous membranes. So if they have other, as I suggested, that HSV-2 predisposes to HIV-1 acquisition, other STDs, ulcerative lesions increase the transmission, and anything that leads to an abrasion of the mucosal surface will also increase the transmission.
Very good, thank you. We have a question I'll pose to you. I think you can answer it quite briefly. Is it possible to misdiagnose syphilis infection with herpes infection?
Clinically, yes.
Of course, yes. Absolutely. Finally, let me ask you this, to talk a little bit more about the molecular methods. I realize that they've arisen and become widely established in your professional lifetime, and so I'd like to hear a little more about that. But then in particular, we have a specific question regarding the use of molecular methods for surface sample testing to assist in the diagnosis of neonatal herpes. Why don't we take the specific question first, and then I'll ask you to make some general summary remarks about molecular methods.
Sure. So yeah, in my career, and one of the fun things, and most listeners will appreciate this, about being in a field over a period of time is you recognize the progress. And so, for example, early in my career, I saw kids with Hib meningitis. I saw kids with, severe complications of chicken pox. And now there's a generation, of physicians, who've never seen such things. In diagnostics, I saw kids who, pretty clearly had encephalitis. How do we diagnose them, right? And, do we do a brain biopsy, very invasive procedure, or do we treat them empirically when we had therapies for a prolonged period of time, which is not without risks? Are we missing the diagnosis? And so in people with HSV encephalitis and in neonates where you're evaluating for the possibility of neonatal HSV disease, as I said, PCR revolutionized that. So you can make a diagnosis or an alternative diagnosis. You could make it quickly. You knew who to treat. You could talk about prognosis, or if they were negative, let's stop going down this dead end and let's refocus and rethink about it and see if we can make a correct diagnosis that may benefit the patient. So molecular diagnosis established their foothold and became the diagnostic method of choice for CNS disease. Now, I think we're also appreciating the benefits for the other diseases. The first two I talked about, the skin disease, the cutaneous disease, and the mucocutaneous diseases. And with increasing availability, where you can do it in your own lab or get a quick turnaround time, it's more sensitive, and you can really make a difference in the treatment of the patients. And so I think this is part of the continuing evolution of testing. But all of us who've been clinicians have been frustrated at times where we think we know what the patient has. The culture is negative, and we're not sure if that culture means the patient doesn't have it, or it was a sampling problem, or a transport problem. And again, with molecular diagnostics, with PCR, we're more confident in the result, and always having a diagnosis makes every clinician happy. Let me know what you have, and then I'll figure out the best way to treat you. And so, PCR was a revolution in diagnostics, and as part of the evolution now, I think it's appropriate to use it in a broader spectrum of clinical cases.
Very good. Thank you. And with that, I will give you the last word with that very, very interesting ending and recommendation. I want to begin now to wrap up. First and foremost, obviously, I want to thank Dr. J. Lieberman. As I said, he gave a magnificent encyclopedic presentation on herpes simplex virus, and it will be well worth studying and sharing over time. I'd also, of course, like to thank DiaSorin Molecular. This webinar was made possible by their special educational grant, and so I'm very grateful to them for that. And finally, I want to thank all of you who are on the webinar, who've joined us today, taking time out of your very busy schedule. We're delighted to be able to bring these to you. We're always interested in getting your reaction and hearing what you think, so don't hesitate to contact us here. And for questions or comments that were not gotten to in our discussion, I do recommend that we will follow up with folks. You can call your DiaSorin molecular technical representatives. We at CAP Today have a lot of facility in handling questions that come in. We'll do our very best to get everyone an answer. So once again, thanks to Dr. J. Lieberman, thanks to DiaSorin Molecular, and most of all, thanks to all of you for joining us today. With that, I'll close the webinar and wish you a goodbye.